Okay, so welcome everybody to our Live Well with Persistent Pain webinar. We're really fortunate to have great speakers today for our session. Just to go through some housekeeping with you all, so just bear with me a second. So just so you're aware, your microphones will be muted and cameras will also be off. This is just so that we have a smooth session, and also so we don't have any bandwidth interruptions as well whilst the presenters are speaking. We also will have the chat box available. There will be time for Q&A. So if you have any questions or anything, you can keep them coming through the chat box. The way to access that is there is a speech bubble on your screens, and if you click on that, there should be a chat box that appears on the right-hand side. Just so that you're aware, as this is a webinar, so we do have many people attending, close to 50 people who have registered. So if you're not an anonymous registrant, then just to be mindful that whatever you do put in the chat box will be seen by whoever's logged on today. Also, just to be curious, so this is an area of well-being that perhaps maybe we've not looked at before or not familiar with. So it's really about lifestyle management and looking at different ways to helping people to manage pain. So just be curious about all the information that comes through today. We'll also, in terms of the timings, so we will have just under an hour today. So we will have some presentations first from our team, and we also have Dr. Ravindran with us as well. So we'll have presentations from them, and then also in terms of the question and answer session, we'll have time to go through anything that comes through the chat box. Just a reminder with the chat box as well, that we just in terms of anything that's specific to your needs, probably keep those to discuss with a clinician when you're next in to see them. But if there's something general in terms of a general query in terms of pain management, you can keep that question coming in the chat box, and we can ask that as a general question to the team today. So I will now hand over to Dr. Bowers.
Well, good evening, everybody. I hope you're looking forward to this evening as much as I am. This has been a few weeks in the making, and I'm really excited, to be honest with you, about venturing in as Brookside practice, just like Fatima says, into a field that we haven't really touched a whole lot on, which is chronic pain management and the changes that have happened over the last few years, in particular in the science and our understanding of chronic pain. So looking forward to venturing into some of these topics this evening. Just in terms of introducing us, you've already met our health and well-being team lead, Fatima, who's really been the key driver about bringing some of this information and getting it out to patients, getting that cutting edge research that's great for researchers, but really isn't very much use when it stays in those kind of environments. Needing to get that disseminated out to folks who are suffering with persistent daily pain. So Fatima is going to be hosting us this evening. Myself down below there, my name's Dr. Mark Bowers, and I'm taking the lead in the surgery for persistent chronic pain, and it's the working group that I'm taking lead of, myself, Fatima, and last of all Tina. Tina in that bottom corner is our clinical pharmacist, and she has a lot of experience in pharmacy. She's been working before she was at Brookside in our community. I think some of you might have known her whilst she was at Boots on Silverdale, and so she brings a wealth of experience. And in particular, where she comes in is when we're thinking about getting patients advice about opiates, about coming down off opiates, especially some of our patients who are on quite high levels of opiates. How do we reduce that when necessary, when appropriate? And so those kind of topics and how are best discussed with Tina, really. The last face there on your screen that I'll introduce is Dr. Deepak Ravindran, and really it's a great honor for us to have Deepak here this evening. I guess we're quite lucky really in Reading that we have access to yourself, Deepak, who's a national lead on persistent pain. Just a few words about Deepak. I apologize for embarrassing you, Deepak, but so Deepak is an award-winning pain and lifestyle medicine NHS consultant. He does wear quite a few hats, both in and out of the NHS. So in terms of his lifestyle medicine and pain medicine work, he's the director of that for Pembroke GP Surgery and Central Reading PCN. So like I say, he's a local lad, lives in the town. He's also an honorary professor at Teesside University. He's a chief medical officer for Buttress Bear, Cambridge, UK. He's the senior visiting fellow at Reading University, and he's also the founder and director of Berkshire Pain Clinic. So if there are some of you who would like to contact him, that might be possible to spend some time through his Berkshire Pain Clinic with him. And also he's an author. I'm sure he'll mention this later, but his books, Deepak's books, have been really instrumental in us as a team here at Brookside getting more informed about the more up-to-date approaches to persistent pain. So I think I'll leave it there. I hope it's okay if I pass this over to you now, Deepak. Really feel very welcome and really looking forward to what you have to bring to us all this evening. Thank you.
Thank you so much, Mark, for that introduction, and thank you, Fatima and Sarah as well, and Tina and the team at Brookside Group Practice for inviting me. And good evening, all of you, for making the time this evening to attend this session here. I'm really grateful, because that's been one of my reasons now. As some of you who may have seen me in the Royal Berks, I was a consultant at the Royal Berkshire Hospital for almost 14 years, and it's only in last July that I moved on to take this role in primary care, working with another group of practices. And it's like working this kind of approach of working with very progressive, very innovative practices like yours at Brookside Group is what gives me the joy to actually spread this message. And the message that I bring is actually one of hope, one of saying that you do not have to be disillusioned or feel hopeless if your medications that you have taken for pain that doesn't work, or the injections or interventions you might have had, or the surgeries you might have had haven't helped. I bring to you the opportunity and the option of a different way to look at it. And as Fatima has said, if you can just be curious with me for the next 30-35 minutes, see what I have to offer in terms of the options that are there, if we can reframe the kinds of pain there are and the wonderful things that your practice is intending to do. That's all I ask of you, and then we'll leave the floor open for questions there. One of the big things that's come through is education for me, making and raising this awareness of how the science of pain has been better understood and can be presented to the public in a more accessible and public health level format, is why I'm part of organizations like Flippin' Pain. And on the slide, what you see here are those simple 6 messages that they are talking about wherever they do their bits. And I'm very grateful to them for them allowing me to sort of use the same 6 messages when I talk to members of the public or patients who might be in pain. And these are the 6 messages: that persistent pain is extremely common. It's not a rare thing. Unfortunately, in the UK, some scientific papers have suggested that up to 43% of the UK population, that's 28 million people, might be struggling with persistent or chronic pain. That means there are more people with chronic pain than all of diabetics, all of heart disease, and all of stroke put together. That number is still not going to touch. So chronic pain is extremely common. There's the other big important message, which I will come to in the next couple of slides, is the concept that just because you have an injury hurt does not necessarily mean that there is harm happening inside the body. Often people get worried that if it is pain, that means there must be something going wrong. And what I'm suggesting is that's not necessarily the case in everyone. And that brings us to the third message, that everything matters when it comes to looking at pain as a form of protection, not necessarily danger. Let us be curious and ask the question, what could be contributing to the nervous and immune system feeling threatened? And that means everything can be important, and it's important to look at all of those things that might be influencing the system. And that brings us nicely to the next message, which I will feature in, is the concept that, sorry, just go back to the previous slide, Fatima, is the fact that medicines and surgeries does not necessarily mean you are going to be getting absolute pain relief. On the flip side of it, we now realize that there are many kinds of pain for which medications and surgeries are not the answer at all. Right from the beginning, they should be not given when you have certain kinds of pain. And it's probably useful to actually understand the kind of pain you have, because that will guide you to the right kind of treatment. And there may be a possibility that some drugs or injections may help, but it is important to see what is the kind of pain you have. So understanding your pain is key, because I now have so many patients and I am witness to so many stories and anecdotes with my work now nationally and internationally, that I'm hearing of people becoming pain-free or certainly recovering and overcoming pain. So recovery is possible. That's why I put this slide. Do you get it? Do you understand your pain? Because we need to remove certain myths that have been with us for a long time. Next slide, Fatima. That the first myth is that pain means that there is some tissue or some part of the body that is getting damaged. Next click. The second myth is that there are very definite pain pathways or nerves for pain. And because if somebody tells you that there is a pathway for pain, or there is a nerve taking the pain somewhere from one part of the body, then the natural tendency is to say, let's block it, let's cut it, let's operate on it, remove it and stitch it up, and then there won't be any pain. But that has actually been proven now to be a myth. There is no such thing as a pain nerve or a pain pathway. Next myth. And the final third myth is that painkillers will kill pain. But that is the biggest of all the myths that has been used by everybody in the medical establishment, unfortunately, because there is no such thing as a painkiller. The word itself makes you feel like there'll be something to kill the pain. But none of the drugs, unfortunately, that we use in our practice actually kill pain. There's only a very small set of conditions where these drugs are incredibly effective, but for most parts, I call them as only pain medications. I don't even use the word painkillers. And this myth approach, the old approach, has to change. Next click. What we are now suggesting and looking at is we need to ask, well, where have these beliefs come from? Certainly, we understand that some of it may come from society, some of it may come from our understandings from 200, 300 years ago when we first started dissecting and looking into the human body and thinking about the pain and mind and body and all of these things. So there is a lot of places where people's beliefs come from. And as culture goes, we are very aware that sometimes our ideas about pain come from the kind of culture we come from the countries, different countries we come from. I come from India. My view is very different from what my parents held, and my parents' view would have been informed by what their parents or the society at that time talked about. Next click. So all of this is very important because we are starting to now make sense in the last 15, 20 years of the evidence that's coming out. So for example, let's look at the story of a builder who jumped from a 2 or 3 meter building site and he landed on that nail that you see. Now, this was a case study that was published in a scientific journal almost 20 years ago. And what they showed was that this builder, when that nail went through, was absolutely in agony. Obviously, he would be, wouldn't he? When you look at that, you would be squirming in your seat looking at that. He was not controllable at the building site. In the ambulance with gas and air, they couldn't control him. In the emergency department, they couldn't control him. So it was decided that he has to go to the emergency theaters, go for a general anesthetic. The surgeon's all ready to clean the wound. The anesthetist has got him off to sleep. The nurse then pulls out the nail and she pulls off the boot, and the surgeon's ready looking to clean the wound. And what do they find? There is no evidence of a physical injury by the nail at all. So they had to assume that the nail went between the big toe and the second toe. He did not have any physical damage at all. But looking at that picture and the fact that he was in agony, you would not think otherwise. You would say, absolutely, he can't be making up this pain. But in some ways, the nervous system and the brain has indeed made that pain happen, that experience happen. This is very important to understand. Next slide. We have now got, sorry, the previous one. We have got the evidence now, so previous one. So here is the kind of injury and the intensity of pain do not have any correlation. That's what studies like this. I have presented one story, but there are so many anecdotes and stories of patients who I have seen and heard where what I see in front of what their scan looks like or what their surgery has been done or what their pain is has no correlation. The intensity of pain has no correlation to the type of injury they have had. Next slide. Now another story. This is an experiment, the research that was done called the Cyberball experiment. In this, the researcher was experimenting on the human participant, and the human participant was joining this experiment where two computer bots were passing the ball to each other. That's why it's called Cyberball. Now, according to the rules of the experiment, the human participant was connected up and his brain had all these sort of dots placed on there, and that was connected to an MRI machine, which was looking at what parts of the brain light up when he's doing certain activities. So at the present or the flick of a switch, the human participant becomes part of this game where the computer participants pass the ball to him or her. And at certain point in the experiment, the researcher flicks another switch and the human participant is not aware, but the computer participant stopped the ball being passed to the human participant. So in a way, what the researchers were looking at is what parts of the brain light up when this human participant is being excluded from the game. In a way, they were trying to say, well, what happens when people are isolated or lonely or they are excluded from certain activities, which parts of the brain light up? And they were shocked to find out that the part of the brain that lights up is the same part of the brain that will light up when you have an actual physical injury, like a surgery or a fracture or a swelling of your knee due to arthritis. So click there. So effectively, the brain cannot distinguish between a physical injury and an emotional thing like exclusion or loneliness or isolation. Now think of that. See how that is. The brain has never been able to distinguish between these two types of pain. But in medical science, in hospitals, we somehow say that emotional pain and emotional problems have to be in another place and physical problems will be seen in a hospital. How flawed is our understanding? That's what the science is telling us. Next slide. So this finally brings me to now the three types of pain. I told you understanding the pain is key. So when you have an acute injury or a pain that is because of a surgery or a fracture or a fall or something that you had on a football field or an injury while playing some game, that kind of pain is called nociceptive pain because chemicals are released at the site of the injury, whether you have a flare-up of your rheumatoid arthritis or osteoarthritis, something like that is called nociceptive pain. The second kind of pain is called neuropathic pain. That's what you see on the top right in the purple, not in the purple, in the pinkish kind of U circle. The neuropathic pain is the pain that you have when you have diabetes related foot pain, or you have got some alcohol related problems, or you have had chemotherapy or immunotherapy for cancer treatment and you're left with pain, where the nerves have been damaged due to surgery or the nerves being cut. That kind of pain called as neuropathic pain. But we are now discovering, and it's only the last 5 years that the name has been given and the new guidelines have come, the new evidence has come, that there is actually a third category of pain, which we are understanding is quite common. In this category of pain called nociplastic pain, the nerves are not damaged, so it's not like neuropathic pain. There's no evidence of inflammation or chemicals being released at an injury site. So there's no surgery or anything like that. So it's not nociceptive or neuropathic. And this kind of pain is due to overactivity or oversensitivity of the nervous and the immune system. So this is a very different third kind of pain. And the examples of such kind of pain are like, for example, conditions like fibromyalgia, conditions like low back pain, many kinds of low back pain, migraine, irritable bowel syndrome. You can think about these, some forms of pelvic pain or abdominal tummy pain. You can think in these pains, you don't have evidence of inflammation on a blood test. You don't even have inflammation shown on any scans. You don't have a nerve damage anywhere in conditions like migraine or back pain or fibromyalgia. But the pain is very real because of the oversensitivity of the nervous and immune system together. Next slide. So how should we be tackling this? This kind of pain is what is now called, you might hear it as different names. It's called chronic primary pain. Sometimes we like to call it central sensitization. There is another version of it, a form of it called neuroplastic pain. So you might hear different names, but they all kind of mean this category of pain where the nervous and immune system is not damaged, not inflamed like a blood test would show, but there is definitely change in the nervous and immune system together. Next slide. So that is why 3 years ago, the guidelines also decided to include this. And this guideline is what is being now shown or sent to all your GP practices, your GP practice, and to so many other GP practices across the country, because we want to really say, how can we assess all chronic pain? And how can we particularly help manage this nociplastic or chronic primary pain? You can see the examples on the right side that I've said. These are the conditions that are called as chronic primary pain. And on the left side of the slide, you can see when you get pain after arthritis or after a surgery or after cancer treatment or after any other problems like you see on the left side, then you have a chronic secondary pain. So these are the two variations. Next slide. And this comes down to actually saying what exactly is happening for an experience of pain to happen. So let's take, for example, nociceptive or the pain where you have an injury. So you have the site of the injury, and then the injury site releases chemicals. The chemicals come from along that black line to the spinal cord. Now, those lines can be any kind of nerves. They don't have to be pain nerves. They can be any nerves, any sensation forming nerves, and they bring it to the spinal cord. The spinal cord acts like the first junction box, which modulates it. It can turn it up or down. So the spinal cord is the first place where things can be altered. And then the information from there travels up to the brain and the spinal cord. Now, the brain and the spinal cord is very complicated. It's like your Alexa or your Siri, or for that matter, the new AI agents that you talk about. Like, I don't know if you've used Claude or ChatGPT, but how do they make their understanding? How do they present the information to you? When they receive new information, they are able to compare it to a whole lot of other information they already have in them. That's why they are called as a large language model. They're trained up before on lots of information so that when the new information comes to them, they can make the right decision and give the right answer. So imagine your brain is also like that. It has already got some predictions of how it should respond. It would say, well, where has the signal come from? Which part of the knee has it come from? Have I had this pain before? Have I had this sensation before? Was it 5 years ago, 1 year ago, 20 years ago, 30 years ago? What did I do at that time to protect the knee? And if at that time protecting the knee gave me the relief and protected me, then I can do the same thing again. The brain doesn't want to waste time making up new scenarios and thinking new ways of protecting. If it has already experienced it before, it will say, you know what, I did it the last time, I'm just going to do the same thing again. All of this predicting and processing and protecting is happening in microseconds or milliseconds or nanoseconds. And the sum total of that, if it says I have to protect, that is when you get the experience of pain. I hope this is clear, because very important, because I hope you're asking and thinking to yourself now, where are these prediction models coming from? How does the brain create these prediction models? And what if something brand new comes that the brain has never had faced before? So the first question, where would these prediction models come from? Next click, Fatima. Well, the brain can take the information from external threats. It will want to take threats information from internally, which is where it gets the information from the immune system at the gut. It can take this information of threats from the distant past. So it might have been something in childhood, some kind of adversity or stress or abuse or neglect or trauma in childhood. If the nervous and immune system together at that time have formed a prediction model that has protected you at that time, it will bring about the same information. And that is important, because all the brain wants to do is constantly look for threat and ensure it can play out a certain safe algorithm quickly and fast. Now, the second part of the question, you may say, well, what if something brand new comes along? Excellent question, because that's where the brain's going to say, if I've never faced it before, what's the safest thing I can do at that time? And if the safest thing is create pain and create the experience of pain, tighten all the muscles, protect that area, scaffold it, then it would rather do that quickly rather than think and solely and sort out and get more information. And that is why sometimes the same thing can happen even though you're not having a harmful threat coming anymore. We are now thinking that in a lot of cases of chronic pain, it's this prediction model that's just not playing right, and the circuits are firing off in an overprotective, oversensitive manner. Next slide. So that brings us to the second part of understanding. If we can be very sure that there are chemicals being released at the site of the injury, and those chemicals are getting converted into electrical signals to travel along the black line, the word for that is called nociception. But when that signal then goes all the way to the brain, and the brain does this wonderful thing of predicting, processing, protecting, and everything, that's when the experience of pain comes along. They are two separate things. Next click. And it's important to look at this separate thing, because if we can be very sure that there is inflammation in the blood test, that there is an active arthritic or infection or something like that, that is the only place where medications and interventions will really work. But for the experience of pain, we really need to think widely. We need to think about what else is the threat systems to the nervous and immune system. Could we change the internal part, which is diet and nutrition? Could we change how the nerve circuit fires, which is sleep and the microbiome and stress management? Could we build new nerve circuits? That is what movement is doing. Could we find ways to calm the whole nervous system down with mind-body techniques? That is what brings the overall thing. That's why pain and nociception are two different things, but they're two very important things, and we have to combine both to create the perfect plan for you as a patient. Next step. So just to recap again, just to repeat it again, if we know it is nociceptive or acute injury pain and there is nociception, the medications, injections, surgeries, infusions will work. If it is neuropathic pain where the nerve has been cut or damaged, it could work. It's not a given, it's less likely, but it could work. But nociplastic pain, that lower category that I'm talking about, the medications and interventions generally do not work at all. And the real challenge is that after 3 to 6 months, both the nociceptive, the one on the top left, and the neuropathic, the one on the top right, will start to behave more and more like the nociplastic, the bottom one, which means that all the techniques that I talked about in terms of nutrition, in terms of sleep, in terms of building new circuits, in terms of calming the nervous system and immune system and reducing the overprotective nature, you have to do it for all 3 kinds of pain. Next slide. And you might be still saying, no, what you're saying, I'm not sure I want to believe you. There must be some medication. And I think there is a definite surgery because your uncle or your aunt or your third cousin, second cousin, sister had something that made the difference. And you're right. It is possible. We need to look at that and we shouldn't write it off. But let me just share with you what is right now the challenge all of us are having. Whether you're thinking about drugs, let's look at all the drugs. Next click. You might have been talked about nerve medication or the opioids like codeine or tramadol, or even the new kid on the block like cannabis, or the old faithfuls like paracetamol or ibuprofen or naproxen. I'm going to show you a very interesting next slide. Don't look at all the numbers in there. So these are there. Focus on the colors. There are 3 colors you see on the slide, the dark green, the light green, and the red. The dark green are all the studies where these drugs that you see on there. Now, these are all the drugs that I use in my pain clinic practice. Your GP can give in the primary care, or your pharmacist can support you with increasing or decreasing for pain management and for mood management. The dark greens are the only studies where the drug is actually better than the sugar pill and is actually making a difference for people's pain. The red is where it has caused more harm and does not work at all. And the light green is where it's kind of middle. So you can see that is the challenge we as healthcare professionals have, is the existing medications right now. None of the ones on the market work for more than 30% of the people, only 30% of the time, and only with 30% efficacy, which means you could be lucky and be one of the 30% where it works, but the chances are you might also be one of the 70% where it doesn't work. So therefore, what do you do? Next slide. As I mentioned there. Next one, this is something different. This is about interventions, about injections. And I'm just going to leave you with some studies that have come in the recent years, just to make you think a little bit. These are studies that have been done on people with no pain. The researchers got permission to do MRI scans because there's no radiation. So they got MRI scans done of, maybe if you look on the slide there, of 43 people. Oh, actually, this has changed a little bit there. There was one previous image in there. So the first image would have shown the slides that were done on people with no pain. And that image would have showed that there were changes on the scan and there would be no pain. Now, after that, the researchers now have done studies where they have compared a sham surgery. So on this picture that you see here, these are the surgeries that have been done where they have taken 2 groups of people. One group of people had, like, for example, let's take the example of this study here on the right side, where you see the circle of the knee. It's called knee arthroscopy, which is a washout of the knee. In this study, they had 160 patients, and 1/2 of the patients were provided or told that they would, nobody was told, let's put it this way. They were brought into the hospital for the surgery. And at that time, nobody was informed, and the researchers also did not know which group the people would be belonging to. But one group of people had a full surgery. They had a full washout of the knee. The other group of people, moment they were put off to sleep and the surgeon was about to make the cut on the knee, the envelope would be opened, and inside, if it said that these people would belong to the sham surgery, the surgeon would only put 2 cuts on the outside of the knee and then just put the bandage back on again and wake them up. So as far as the patient was concerned, they have come to hospital, they have been fasted, they have worn a surgical gown, they have come into the theater, they have gone off to sleep, and then they wake up with a bandage on their knee. So they don't know whether they are the group of patients that have had their knees washed out or whether they have had a sham procedure. And they followed these groups of people for 1 year to see how did they do with physiotherapy? Did their pain relief reduce and they took less medications? Did they go back to work? And the reality is that after 12 months, there was no difference between both these groups of people. The group of people who had the full surgery as well still needed the medication, still had the same people that went back to work or not, and the people that went with physio. And the people who had the sham procedure, meaning they didn't have the washout, they just went to sleep and woke up, also did the same. So this has really raised a very ethical question. What is surgery actually doing? Is surgery an expensive placebo? And that is a real relevant challenge that many people are thinking about. And that is one of the reasons why the knee washout right now for many of you is like a procedure where your surgeon has to really explain to you the benefits, the risks, the alternatives, and has to take permission because it's not routinely offered on the NHS anymore. And that is why other surgeries like shoulder washout or tennis elbow or back surgeries have also become less and less in number because success rates are not great. Next slide. And this is why I tell all patients, and I would encourage you as well, because we are now understanding these things, whether it's an injection, whether it's an infusion, whether it's a surgery, whether it's a manipulation that you have with an osteopath or chiropractor. Make sure you understand the benefits of what they are doing, the risks of what they are doing, what might be the other alternatives, and actually what if you do nothing. That's called the brand principle. Because for the right patient at the right time, any one of these surgeries or medications can make a difference, but unfortunately, it does not mean it will work in everyone. Next slide. So my final point before I hand back to Mark is now that you hopefully understand what kind of pain you might have. This might give you some ideas on what are the kinds of pain you could be having or have had. It's important to not throw the baby out with the bathwater. I'm not saying that medications may not work, but all I'm suggesting, like you see on this picture in front of you, if you want to overcome pain, you now realize you actually have 7 things you can do to overcome your pain and potentially become pain-free. You don't have to be restricted feeling if the drug or the injection hasn't worked, it's hopeless, because there are 5 other things that could make the difference. And this is what I have been talking about nationally and locally. We've been looking at how we can get these 5 things to you in a way that's useful, that's fun to do. We think groups are a wonderful way of doing it. We think getting help from each other is a wonderful way of doing it. We think the faster you get it, the closer you get it to your home. That's a great thing rather than sitting on a waiting list to a pain clinic. And I'm so grateful that places like Brookside Group are taking this innovative option of creating a community, talking about a cafe, providing that coaching arm, doing it as workshops. So I think this is a great place to actually let your GP colleagues and Dr. Bowers sort of explain to you what it is that I'm doing. A lot of what I've said is there in the book that I've written here. This is probably the only place to plug the book there. But I hope that this kind of information change and this way of supporting people in primary care happens more often. So over to you, Mark. Thank you so much for having me.
Well, Deepak, thank you so much on behalf of us here at Brookside for bringing that real tour de force of your research and of others, and you know, I really appreciate your time this evening. Before I lose anybody's attention, thank you for those of you who have stuck through that presentation and for the time you're investing in your health. Fatima, would you mind just popping through the next few slides so that just comes up there? So I you know, this is the moment where really it's my invitation to you. It's our call from Brookside. You know, you've heard a lot there from Deepak. You know, I hope, you know, you've caught something there of the hope that Deepak has presented to us. You know, as clinicians, you know, certainly, you know, some of us do have, I guess, some antipathy or some reluctance to be prescribing folks higher and higher levels of opiates in particular, or other medications that are related to pain that we know have side effects. You know, we know that they can cause trouble for our patients, and that can be functionally in terms of brain fog, but it can also be things like constipation, significant constipation, sedation, etc. So, you know, there's that side of things. Is I don't want to be, you know, giving patients unhealthy amounts of pain medication, but also for sufferers, for pain sufferers like yourself. I hope just hearing Deepak has made you think, you know, gosh, there may be another way. There may be another way of tackling my persistent pain without needing to be increasingly reliant on painkillers, and also really that as Brookside, I hope you feel that you are being seen, and we know that being reliant on daily painkiller medication is not what you want to be doing. That's not the lifestyle that you want. So a couple of really important things. The first thing is the workshops that we're instigating. Now these are 2 evening workshops to introduce a life-changing program. It's called Living Well with Pain. We're going to be meeting with other patients who have really transformed their life. We're hoping that they'll be there in person. You can ask them questions. They'll be kind enough, brave enough to share their experiences of how taking a different approach than maybe they had been using before with their chronic pain, with their daily persistent pain, has actually helped them radically. So if that interests you, if you feel inspired by what you've heard this evening from Deepak, and you want to go a little bit deeper, you want to start thinking about how you can put that into practice, why don't you log in? There's a link there that my colleague Sarah has posted in the chat. You know, just register for that workshop. It will be a fantastic time, 2 evenings. I've got the dates here. It'll be on March the 4th and the 11th. It will be in Maiden Place. All the details will be on the website, 6:15 in the evening to 7:30. It would be really good to see you there. The other thing to flag up is the health and well-being coaching. You know, our host this evening, Fatima, and her team of health and well-being advisors and coaches take patients through a Living Well with Pain course. So that again is an opportunity for you to go one-on-one, maybe kind of focusing in on a few areas of your life that you think might begin to turn the ship of your symptoms. So that if you want a more personalized approach, maybe you don't fancy being in a big group, then by all means get in touch with Fatima and her team. I think there's another link for that as well. The next thing, medication management. Yes, we do have some pharmacists. We do have some pharmacy appointments available, and remember that's in-house pharmacy. So, you know, if you just contact Brookside the normal way, ask to speak with a pharmacist, you can have a chat with them about reducing your medication. But really, I would encourage you, maybe before you've done that, educate yourself a bit more. Get in touch with us through the workshops or through the health and well-being coaches. So yeah, really this evening I would encourage you, commit to one of those so that we don't lose momentum off the back of this evening. Next slide. Thanks, Fatima. In fact, that's over to you. Appreciate it.
Thank you, Dr. Bowers. Thank you, Dr. Ravindran, as well. Really inspiring presentations and talks today, this evening, and I hope you've all found it helpful for all of you that are attending this evening too. Just forgive me if I'm looking at 2 screens. I do have 2 screens. So if I'm looking here, it's because I'm looking at the chat box, and if I'm looking here, it's because I'm looking at the presentation. So apologies if it's a little bit disjointed. So this is just a slide that talks through the Live Well with Pain program, and this is what we, our health and wellbeing team, work through with people one-to-one. So what Dr. Bowers had mentioned about the health and wellbeing coaching support that we provide at Brookside, this is what we would help you to do do if you chose the one-to-one support. We will also be talking about this program in our group sessions. Just a little bit on the group sessions, just so that you are aware. We do have a maximum capacity of 40 people that can attend. That's 40. The reason for that is because the room that we have secured at Lower Early Baptist Church only takes 40 individuals in that room. So it would be a first come, first serve basis. So if that is the first step that you'd like to take, please do register early to avoid disappointment. There was a question in the chat about running other groups because of being unable to attend on the 4th or the 11th, 4th and the 11th. For the moment, we will see what the take up and interest is for those 2 sessions, and then we will be in touch if we will be running further groups. But I'll hand over to Dr. Bowers. You might find the resources on the next slide helpful as well.
Okay, great. Thanks, Fatima. So yes, like we've mentioned already, if you prefer using your mobile phone, there's QR links for the new workshops in March. There's a QR link there for the health and well-being coaching. Really just want to get these resources out to you as best as we can. Some of the resources below in that bottom half of the slide. You've already heard myself and Dr. Ravindran mention about his book, The Pain-Free Mindset. So feel free to purchase this. It's in Amazon and all good bookstores. A few websites there below. The Living Well with Pain website. They're a UK-based organisation that is being is mobilising itself and mobilising GP surgeries across the country to get some of this information out there. Let people know that living with pain doesn't have to be a case of just being reliant on medication for their whole life. There's another website there, Pain Concern Self-Management Navigator Tool. Got some great resources. Do have a look at that as well. Tame the Beast. It's an Australian site, Australian agency that again makes really good videos. If you want concise 5-minute videos that just explain some of what Deepak has explained to us this evening, that's a good resource to if you want to speak to friends or family about what you've heard this evening. That might be something that you'd like to log on to their website and just see what they have to say. Flippin' Pain, I think we have to give a hat tip to them, only because Deepak is really representative of them. He wears he's one of their ambassadors. So yeah, they're doing really good work as well. And again, their website is there if you want to gain access to their info. More of a face-to-face or in-person resource there, that bottom one, Escape Pain. That's a course that Bulmersh Leisure Centre are running for 12 weeks. There is a cost associated with that, but that's particularly for folks with arthritic pain, and the Wokingham Council are investing in a course that's specific for pain sufferers with arthritis, trying to get them moving through their pain. And actually, as I'm sure some of you with arthritis will know, movement can actually be quite powerful when those muscles around a joint are strengthened. Amazing things can happen with the severity of someone's pain. So that might be a resource for you, in particular if you suffer with arthritis, and you can either contact the Leisure Centre of Wokingham Council directly, or you could speak to us. We'll probably have a bit more information about that in the workshops in March. If you're coming along, you can grab us and ask us about that. Back to you, Fatima. Thanks.
Thanks, Dr. Bowers. Okay, I'm just going to stop sharing my screen just so I can bring the Teams channel to here. So I'm just looking at one screen. Brilliant. Okay, so I can see somebody's saying that you can't hear us. You might have to log out and log back in again. More often that solves the IT issues. Sorry about that. Okay, so yeah, just a little follow-on note on the Bulmer Center Leisure Center the Places Leisure team that they're running the escape pain course. So they do have eligibility criteria. So Dr. Bowers did mention the arthritis aspect of it. I believe it's also for hip and knee pain. So I think the information with regards to the escape pain program will be going live on the Places Leisure website in March, is what we're told. And the sessions will be starting in April. But yes, as Dr. Bowers said, we should have some more details for you in March, especially for those of you that will be joining us face-to-face as a group session. Okay, so I'm just going to go through the chat now. Please do keep questions coming in, and we'll try our best to answer them. We've got about 8 minutes left. So let's have a look. Okay, so there is a question there, Dr. Ravindran, for yourself. So wanting to have some further conversations with you in relation to chronic pain for the partner. So do you want to come back on to Mike and give some advice?
Absolutely. Thank you so much, Mick, for sharing that part. I think cluster headaches are one of the most challenging forms of headaches to really resolve or reduce. Our understanding of it is that it lies in this difficult place between nociplastic and neuropathic, meaning there are changes somewhere in the circuits of the brain and the migraine center that seems to be driving all that. And that's why sometimes all the interventions and the medications you've tried may not have worked or hasn't been able to keep a sort of appropriate balance. Certainly in a lot of these patients, there is suggestion that looking at the forms of supplements they're having, what can be looked at for calming the nervous system down, optimizing some of the firing and the aims around sleep, as well as nutrition management, can make a big difference. So I am certainly a fan, or at least a very enthusiastic proponent of saying, let's look at the whole person picture, because if the guys and Tommy's guys have done the medications, have even tried a nerve stimulator, then we are reaching the point wherein what they can do traditionally is at a loss. Then I think we should even more double down on saying, well, what could we use to calm the nervous and immune system down? And that might mean lots more of everything that I spoke about. How do we bring all those things in a nice plan, supported, and take it and then see how it is over a 3 to 6 month period. So that's the way I'd approach that there. I appreciate that's probably with a group setting, that would be the best information I can give at this time without knowing all the other clinical particulars or the background vulnerabilities for the nervous and immune system.
Thank you, Dr. Ravindran. So I can see a hand up. Unfortunately, we won't be able to put you on screen or enable audio just because of the settings of the webinar today. So for any questions that you have, just a reminder to put them in the chat, and then we can have a look at those. Okay, so yeah, so Mick's just saying thank you, Dr. Ravindran, in the chat. Okay.
Thanks, Mick.
Okay. So, yeah, and we will be posting the recording to this webinar on our surgery YouTube channel. So for anyone that wants to go through the presentation again today, or maybe you missed the QR code or any links, anything to that effect, you will be able to watch the webinar again on our YouTube channel. So we're looking to make that live within the next week or so. So just keep a lookout on that. We still have, probably take one more question if anybody has any.
Do you mind if I jump in with a question, Fatima? So I guess my question, Deepak, is for those patients who are on pain medication and who may have a nociceptive or a neuropathic process, that is to say, an organic or a structural problem. Is it dangerous for us to be talking about reducing analgesia? I mean, what is to say is I wouldn't want any undue harm to come to a patient when we would approach a more holistic approach to their pain. Or is it the case that regardless of what the cause of pain is, that it's always reasonable to be thinking about holistic approaches to pain?
Thank you, Mick. Thank you, Mark. That's a great question there. And it's a very important question because the research right now suggests that 30% of all nociceptive pains will have a nociplastic component that gets progressively bigger and bigger as time passes. Up to 50 to 70% of neuropathic pain will have a nociplastic element that gets bigger and bigger as time passes. And by time, I mean 3 to 6 months onwards. So for anyone who may still have a ongoing nociceptive, so let's give it a clear example. Let's say someone has got rheumatoid arthritis. It's an autoimmune condition, and we know that sometimes it can flare up. The blood test might show that the RF factor is high, the CRP is high, everything's gone high. And you can say, okay, that person has got a nociceptive pain happening. But that does not mean, and you might say, okay, let's look at their biologics, let's look at tweaking their pain medications, or maybe increasing their opioids or something like that a little bit for their acute phase. But it is very important to bring that other element of what else can we do to calm the nervous and immune system down, because rheumatoid arthritis has got an immune system that is flaring up and is activating the nervous system so much. So you can control the immune system, but you can have other ways to control the immune system through nutrition, through sleep optimization, through movement and mind-body techniques. And that might be an example for someone who's having an active nociceptive focus. But for everything else, coming back to your question about can you try to reduce the drugs, is there going to be harm? The short answer is no, there will not be harm. And there is everything to be gained by at least having a conversation with people who are on very high doses of opioids or gabapentinoids, because we now know that there is harm happening because of the high doses of those drugs. So it's always worth having a conversation to say, how much is this drug helping you? Do you want help in even reducing it a little bit? Even 10%, 20%, can we just make an attempt to taper it, but give you something otherwise, like a group-based approach, like the cafe approach, like some other activity that can calm the nervous system down, something of nutrition. And if it does work, fantastic. You're actually on 10 or 20% less. It will make the patient feel confident that they can try to come down some more. And for some reason, it doesn't work, the pain feels worse, we just accept and say, okay, we tried, let's revisit it in 3 or 6 months' time and go for it there. So that's the way. So there's certainly no harm. And I think it's an approach that we should try, but it should be done with the patient, like what you're doing now, with the pharmacist, with the health coach. It's a shared decision-making process.
Excellent. Thank you, Deepak. Thank you.
Thank you. So just as one final question, I'm happy to take this one. So it was about what do you do if regarding what would you suggest if you know what to do regarding sleep, nutrition, exercise, etc., but the pain still doesn't go and you're in too much pain to do it? Yeah, that sounds really challenging. So what I would suggest is there is so much information coming out now, so many resources also coming out now. Please do come to the group workshop. I think sometimes also speaking to others who are also experiencing pain. Of course, everybody's unique and going through different elements of pain. It's impacting people differently. We appreciate that. But sometimes the sharing of that knowledge, you might even go away and say, you know what, I've spoke to somebody today and I really wanted to try that tip that potentially worked for them. And, so it's very much about a learning process and just putting that together and finding out what works for you. But we truly believe that, our hope is that there is something out there that will help everyone to manage their pain in the best way that they can. So I hope that was helpful.
I would second that, Fatima, and Bhakti, I can assure you that I have met a lot of patients who have been in that similar kind of situation. All I would suggest is, if the existing status quo that you're in isn't working, what would be your next step there? If what I've told you is your nervous and immune system is flaring up and there isn't a suitable drug to do, what could be the next step? What could be the smallest thing that you could do for a minute that would be a small step in the right direction? That's all we're asking you to do. And that's where Fatima's suggestion of doing it and trying it in a group is a good thing that you could at least explore.
Great. Okay, so we've reached the end of our session today. So thank you so much, Dr. Ravindran, Dr. Bowers. We've had so many people behind the scenes to make this evening possible. And also thank you to you all for joining us today this evening. Again, we hope you found it helpful. And as I say, the session will be recorded and will be available on our YouTube channel. Apologies for anyone who's struggled with the IT, but again, hopefully rewatching this session will be helpful in the next week or so. So we look forward to seeing you in March, or perhaps face-to-face too, maybe as a point, kind of, if we look at goal setting, what is one thing that you've taken away from today's session that you feel you want to try having a go at in managing your pain differently for the long run? Okay, so take care. Have a good evening. Take care. Bye-bye.
Thank you all. Good evening. Thank you, folks. Thank you, Deepak.